Okay, I guess we'll get started. It's a little after 2. First of all, thank you guys for being here. Pediatric session for CAGLA. Very proud that we still have a pediatric session. It's been part of it since the beginning. And, we're always small and we always get one day, but that's true at most of the national meetings as well, right? If you go to, any of the big meetings, ASCO or ASH, tandem meeting for transplant, PEDS is always put off to their own side, right? Which is kind of funny because PEDS has led the way in a lot of areas, of transplant, cellular therapies, and things like that. We're a small group, and our patients are smaller, but I think we hit way above our mark. Before we actually start with 3 great talks that we're going to have today, we usually do 4, and we decided to keep it to 3 because those of you who were with us last year and the year before know that we often run a little over, and then they start the second line during our 4th talk. So I'm not going to be talking about the treatment of pediatric or ALL or adolescent lymphomas. I am going to give you 2 updates on that, but I'm not going to give a full talk on it. I am, however, going to be giving a talk tomorrow in the hematology group on the treatment of ALL in adolescents and young adults. So I encourage you guys to come to that. One of the things that I want to say before we go to the talks, though, is advocacy is what we are. Right? CAGLA was founded to advocate for pediatric cancer patients. And right now, that's becoming even more important, right? Both our state and national level. You probably have all heard about the cuts in funding for a lot of our science that's going on. And I know everyone in here is, I would assume, in favor of scientific research. So I want you to use your voices in any way you can to advocate to continue the basic science and medical science research, because cutting that funding hurts our patients. It hurts all of us. All right. So our first speaker today, I love introducing because we did fellowship together at the University of Chicago, Dr. Navin Pinto. Dr. Pinto is an extraordinary doctor and a great guy, and I can't imagine having done fellowship with anyone else. He saved my butt many times during fellowship. He used to say, "You're the yin and my yang," which was true. Navin went, after spending some time in Chicago after fellowship as an attending, went to Seattle and was in Seattle for several years. His area of expertise is neuroblastoma and other solid tumors. In Seattle, he worked with Dr. Julie Park with CAR T therapy for neuroblastoma. He left Seattle about 2 years ago and now is at Denver Children's, where he's heading up a solid tumor group. And he is actually the PI for the upcoming high-risk neuroblastoma study that hopefully will open in a year or so. Right. Great pleasure to introduce Dr. Pinto.
And thank you all for having me. This is my 2nd year in a row at CAGLA and hoping to make this a tradition. I really enjoy this conference and really excited to be here. So I'm going to step a little bit out of my comfort zone. And as Bob mentioned, I am a solid tumor doctor, and I am going to mostly talk about leukemia today. So if I mess anything up, please let me know. So I'm going to talk a little bit about CAR T-cell therapy and sort of a review of the current state in pediatrics and hopefully touch on some future directions. I have no financial disclosures to report. And wanted to start out with this slide. So many of you may have seen similar pictures. This is Emily Whitehead, one of the first patients in the world treated with a genetically modified T-cell therapy to treat her leukemia. As the doctors that treating her attending physician there, Dr. Grupp, is standing over her bedside on the left-hand side of the slide and is infusing her with CAR T-cells. This was in 2012. She was on death's door when they decided to go for this treatment, had run out of conventional therapeutic options, and was being treated in a first-in-human phase 1 clinical trial, really with very little hope that she would survive. And now this slide is actually a little bit out of date because I only have 10 years of follow-up here. She's now celebrating her 12th year being cancer-free. After a single dose of CAR T-cells, and interestingly got no further therapy after this, and at least last I heard, still has detectable CAR T-cells floating around in her blood. So she received this living drug that is cured her of leukemia, theoretically, and is surveilling for any aberrant cells that may be hiding out. So the objectives of this talk are to go a brief overview of cancer immunology, quickly give a 101 on how CARs are built, review data behind the only FDA-approved CAR T-cell therapy in pediatrics, and then describe some of the side effects we see when treating patients with these therapies. And then briefly, hopefully I'll have time to touch on future directions for this technology. So cancer immunology, or using the immune system to fight cancer, is not a new concept. This is Dr. William Coley, who many of you may know, who had an astute observation of a patient with a bone sarcoma who developed an erysipelas infection and had a really significant soft tissue infection near their site of their tumor. And I believe when they went to amputate the leg, both for the infection and the tumor, noticed that the tumor was completely necrotic. Now, this was before the era of conventional chemotherapies, and really amputation was the treatment of choice. And so to see a completely dead tumor as the result of an infection was a remarkable discovery. And so Dr. Coley at Memorial Sloan Kettering tried to take advantage of this. And so first he started just injecting people with live erysipelas bacteria. And I think of the first 3 patients he treated, 2 of the patients died of sepsis. And so he refined his strategy and heat treated the bacteria and used sort of what we now know as the sort of bacterial cell wall of the bacteria, and had many responses. So developed a therapy called Coley's toxin that he infused patients with. And again, this hasn't survived because it wasn't an all that effective strategy, but there were occasional responses to this. And the thought was, even in these days, that over 120 years ago, that activating the immune system was capable of eradicating cancer. So this is a schematic or a cartoon of how the immune system sort of interacts with either infected or malignant cells. And let's see if I can get a laser pointer here. This is the T cell side, and this is a antigen presenting cell side, which could be an infected cell or a macrophage or a tumor cell. And oftentimes these cells present fragments of proteins or peptides in the context of the major histocompatibility complex, or MHC. And those are received by a T cell receptor. And these are a conglomerate of proteins that are meant to recognize various proteins. And if there's a co-stimulatory signal given, that activates the immune system to destroy this target cell. And so this is a very complex interaction of both yes and no signals that tell the immune system what is self, what is infected. And this has to happen in a very elaborate dance or a harmonization of activation and inhibition. So we're not constantly rejecting our heart or our brain or our thyroid and only getting rid of infected or malignant cells. Now, cancer has figured out ways around this, of course, and one of the major ways that cancer gets around this is by downregulating MHC. So it does not necessarily present peptides or overexpresses some of these immunosuppressive peptides like PD-L1 or PD-L2 to tell the immune system, hey, I'm supposed to be here, don't worry about me. And engineering T cells is a way around this. So this is a schematic of how we can engineer the immune system to fight cancer. So again, this is sort of the natural state of affairs of the antigen presenting cell with a peptide and the T cell receptor. And through genetic engineering, each one of these little colored figures is encoded by a gene. And so, or I like to think of these as like little Lego blocks encoded by genes. And you can encode these Legos and assemble them if you know the genetic structure or code of these proteins. And so This can be done both with artificial T cell receptors that are engineered to recognize a specific cancer-associated protein, or can be taken a step further by combining antibody technology, which we know binds to proteins on the cell surface, with some of the activating proteins that are involved in the natural T cell response. So again, you know the code to some of these activating proteins. You can develop a synthetic gene and knock that gene into a T cell and develop this Frankenstein molecule, essentially, that can recognize proteins on the surface of cancer cells. And why this is important or revolutionary is that, as you can see here, you don't necessarily need this MHC presenter molecule. You can go directly after proteins that are on the surface of cancer cells. And so, we know that cancer can downregulate MHC and may not actually be presenting these small fragments of proteins, but maybe you can go after proteins that we know are on the surface of cancer cells, but not on the surface of healthy cells. And so that's where this technology sort of took off. So you may all know this, and so I'll try and go through this quickly, but this is not at least currently, a drug that you can prescribe from a pharmacy and pull off the shelf. These are therapies that are manufactured from the patient. So this is a cartoon showing a patient who undergoes a therapeutic apheresis procedure where billions or trillions of T cells are collected. Currently, the main mechanism to insert these genetic codes, these Lego pieces into T cells to create a CAR, is used with inactivated viruses. So these are viruses that are not capable of causing an infection, but are capable of delivering genetic signals. Once the T cells are infected, they're stimulated with proteins to grow and expand. And then, as you can see, all of these T cells are now carrying this new CAR signal. They're purified and frozen down, and the process of making these CARs takes anywhere from 7 days to 3 weeks. And once the cells are ready and the patient is stable, they can be injected into the patient. And there's all sorts of technologies of trying to get rid of viruses along the process, trying to shorten the time of manufacture, and safer ways to deliver these engineered treatments to patients. And I think we'll hear a little bit more detail about this today, but the only FDA-approved therapy for pediatric patients with using CAR T cells is targeting a protein called CD19 on B-cell malignancies. And so this is just a brief description of the sort of revolutionary trial that Emily Whitehead was a part of, showing really remarkable response rates and survival outcomes for patients treated with this CD19 CAR. Again, these were patients that were almost certainly bound to die from their relapsed or refractory leukemias, and at 81% of patients who were treated with this CAR went into a complete remission, and over 50% of those were sustained. I mentioned here that this is not an intention to treat analysis, so not everybody that enrolled on this trial was stable enough to wait the 3 weeks to get the CAR T cell, and the 81% response rate were for those patients that actually were stable enough to get treated. So Kymriah, which is manufactured now by Novartis, is FDA approved for children up to age 25 with pre-B-cell ALL. That was approved in 2017. And sort of the real world experience with this CAR T cell is that about 50 to 80% of patients will enter a complete remission with relapsed or refractory ALL with this technology. There are all sorts of CAR T cells in the works, and many more CAR T cells that are FDA approved for adults, mostly with B-cell malignancies, non-Hodgkin's lymphoma, multiple myeloma. And for the sake of a 30-minute talk, I don't have time to go into all the data for those. But again, I think most pediatric patients who are in need of novel ALL therapies are reaching for Kymriah. So we'll talk a little bit about some of the unique side effects of these therapies. because these are immune cells that are releasing cytokines to destroy their target cells, it sort of makes sense that one of the most common side effects is something called cytokine release syndrome, which is a constellation of significant, sometimes life-threatening symptoms, most commonly fever, and then constitutional symptoms similar to an infection. So these are symptoms that are very, very similar to severe COVID-19 or the flu or sepsis, where patients have fevers, have low blood pressure, arthralgias. And there's an interesting story from Emily Whitehead that when she was treated very quickly, within 7 to 10 days of her CAR T-cell infusion, she got very, very ill. And this was, again, the first pediatric patients treated with this technology, so there wasn't a lot of knowledge of what to do. She was having high spiking fevers, low blood pressure, was in the ICU, looked very ill, like she might pass. And the team really was struck with what to do. And they measured serum cytokines in her blood and saw that several cytokines were very, very elevated, most notably IL-6. And really, in just a leap of faith, the team at the Children's Hospital at Philadelphia said, well, the rheumatologists use an IL-6 blocker to treat some rheumatic conditions. That seems like the only cytokine blocker we have in our pharmacy. Why don't we give that to her? And very quickly, her fevers abated. She was much better out of the ICU. And then we saw the end result with all those happy pictures. And really, as we've treated more and more patients, we've learned that severity of cytokine release syndrome really does correspond to how high your IL-6 level goes. So patients that developed grade 3 or 4 CRS had much, much higher levels of IL-6 compared to those that developed no CRS or very mild CRS. And the same goes for patients with interferon gamma. So that's another cytokine that many are interested in blocking in patients that are quite ill. And you can see here just sort of the rises for 2 selected patients on the original phase 1 study of IL-6 levels, which correspond to some of the clinical markers like CRP. So in part, based on our experience with Emily, the tocilizumab, or an IL-6 blocker, became a mainstay of treatment for cytokine release syndrome. And although it was FDA approved for rheumatoid arthritis in 2010, the FDA approval was extended to treat CAR T-cell mediated CRS soon after CAR T-cells were FDA approved. Now, tocilizumab is an antibody that does not cross the blood-brain barrier, and we'll talk in a little bit about how some of these cytokines do get into the central nervous system and may mediate toxicity. So there are other drugs that people are now relying on a little bit more, like siltuximab. And then again, steroids as an immunosuppressive treatment are really a mainstay. And this is just a cartoon for reference of how many people approach CRS. It used to be thought that you wanted people to develop a lot of these side effects. You wanted them to fever. You wanted them to go to the ICU. I've even heard doctors say, let's do the shake and bake. Let's get them, rigoring and fevering and get them to death's door, and then we'll break out these meds. And I think we've learned along the way that that's not the case, that you do not necessarily need all of the cytokine release to mediate anti-tumor effect. And so one of my colleagues in Seattle, Rebecca Gardner, published a paper showing an early intervention strategy that at the first sign, essentially, of cytokine release, essentially when people had sustained fevers over 38 degrees or any hemodynamic instability, before the CRS would reach grade 3 or grade 4, you would reach for tocilizumab and steroids. And interestingly, although we thought maybe this might inhibit CAR T-cell proliferation or effect on leukemia, we found absolutely no effect on this early intervention strategy in CAR T-cell expansion or persistence or anti-tumor effect. And so I think there's a a move earlier and earlier to prevent some of the side effects of CAR T cells without impacting their efficacy. And I think there are even some adult studies now that are doing preemptive tocilizumab before any toxicities develop at all. Neurotoxicity is another potential toxicity of CAR T cells. In fact, it has its own name now. This has been some good job security for people in the field to develop new names for some of the things. And so the CAR T cell term is immune cell effector associated neurotoxicity syndrome, or ICANS. And this is a different constellation of symptoms of inflammation in the central nervous system. This tends to happen in patients with a history of CNS leukemia or heavily pretreated CNS disease with radiation or lots of intrathecal therapies, but not always. Some patients without any history of CNS leukemia do develop this ICANS syndrome. And so this neurotoxicity syndrome does exist as a black box warning on many of the FDA-approved CAR T-cell therapies, in part because there have been some fatal cerebral edema events that are very rapid in onset and very, very difficult to treat. Some of the warnings of this, again, are seizures, delirium, word-finding difficulties, signs of increased intracranial pressure. And it still remains largely unclear what is causing this. There's thoughts that the CARs mediate a disruption of the blood-brain barrier, that there's endothelial dysfunction, obviously cytokine release into the central nervous system. And oftentimes when patients are experiencing these toxicities, you can find the CAR T cells in their central nervous system. Steroids remain the mainstay of treatment for ICANS. Oftentimes these patients also have other symptoms of cytokine release, so tocilizumab is used very frequently. And heavy-duty supportive care. These are patients that go to the ICU or often intubated for protective airway measures, may even be systemically cooled, may have neurosurgical interventions. And there are some patients that, despite some of the severe symptoms and life-threatening symptoms, do make it out the other side, hopefully in a remission. And then finally, the other main toxicity that we see that can be unique to this group of therapies is an HLH, or hemophagocytic-like syndrome, or macrophage activation syndrome. In fact, we've also coined a term for this called IECHS, immune effector cell hemophagocytic syndrome. Again, this looks very much like HLH that we may see in other patients, and this seems to be mediated by profound macrophage activation, and this happens in a subset of CAR-treated patients. Again, it remains unclear who's at risk for this. There seems to be some tracking with the type of CARs that are used, what co-stimulatory domains or what Legos you choose to build your CAR, and that there are probably some patients that are genetically predisposed to this syndrome. The presentation of IECHS involves very high levels of ferritin in the blood, cytopenias, and then end organ toxicities, predominantly in the lungs and the liver. The treatment of this I marked as in evolution. I think many places are doing HLH-directed therapies now. Steroids are a mainstay. And I think there's an increasing use of interferon gamma blockers like Gamifant to treat this with some pretty good success. As an aside, my day job is to treat solid tumor patients with CAR T cells, and so none of those therapies are FDA approved, so I won't be talking about them. But this seems to be a more solid tumor focused toxicity. So we see a lot more IECHS in some of the more active solid tumor CARs. Obviously, none of those had made it to the clinic as an FDA-approved therapy yet, but it's interesting that the pattern of toxicities we see in different malignancies is different. So in ALL, you may see more CRS and more neurotoxicity. In solid tumors, we saw zero neurotoxicity, very mild cytokine release syndrome, but more prominent HLH, or macrophage activation. So there's although this is very, very exciting, and it's amazing to have a new FDA-approved therapy for patients who were previously out of options, there's still a lot of challenges. And on the far right, the challenge I deal with most is getting these to work for non-liquid malignancies like solid tumors of bone or nerve or muscle. The same goes for brain tumors. Some of the toxicities are very scary. In fact, we've had several patients that have been treated with this technology who have entered a remission but have died of toxicities, which is always one of the most heartbreaking things that we encounter in our field. And as cancer is wont to do, it can figure ways around this. So antigen loss, you're targeting a single antigen with these CAR T cells. Cancer can figure out a way to downregulate or mutate that target and survive without that target on its surface, and then the CAR T cells really have no effect. And then finally, in very, very heavily pretreated patients, sometimes making or manufacturing these CARs can be a challenge. And so product failures are a very real problem. And then the waiting time that I'm not just able to pull this off a shelf and prescribe it to a patient as soon as they need it, and that they may have to wait 3 weeks before they're eligible for this therapy. Sometimes that 3 weeks is too long. So we'll talk a little bit about the limitations. I'm going to buzz through this because I'm already over time. I apologize. So about 50% of patients will relapse after CD19 CAR therapy, and antigen negative relapse, loss of CD19 seems to be one of the major mechanisms. So CD19 loss can be mediated by mutations in the CD19 domain that either lead to a loss of the epitope that the CAR is targeting, sort of this blue loop here on the cell surface. That can be mutated out, so the CAR no longer recognizes its domain, or it can be unhinged from the membrane and not expressed at all. Another thing that we've run into more frequently than we would like is lineage switch, that some patients who present with ALL are successfully treated with CD19 therapies, then switch and develop acute myeloid leukemia, and these can often be much harder to treat. It's thought that the constant pressure on CD19 may drive this lineage switch, and it's been seen with other CD19 therapies like blinatumomab. So how are we getting around this relapse strategy? We're going after other targets. CD22 is another target that is on ALL. I'll breeze through this. I apologize for going over. And this is some phase 1 data from the NIH, NCI, showing pretty dramatic response rates. These are several patients that developed CRs to a CD22 CAR. And we know that this CAR is active in patients with either 19 negative or 19 dim or even positive ALL. So what are we working on next? So my partner at the University of Colorado, Terry Fry, developed a bivalent 19 and 22 targeting CAR T cell. There are lots of ways to put multiple CARs into a cell. You can either co-infuse a 19 or a 22 CAR or co-express, but Dr. Fry chose this approach. And both preclinically showed very, very brisk leukemic responses, and now is being investigated at a trial at the NCI, although I heard, to Bob's point, that they're no longer allowed to enroll and treat patients at the NCI currently, Stanford, and at our center at CU Anschutz. So several limitations still exist to this very exciting technology. We need earlier interventions for CAR T cells rather than waiting until patients are on death's door. Manufacturing can still be an issue. We need better toxicity mitigation and management strategies. We need ways to turn off the CAR T cell if they're mediating severe toxicity. And then there's lots and lots of unmet needs in cancers of lymphomas, solid tumors, brain tumors. And CAR T cells are even being used to treat autoimmune disease. So there's lots and lots of activity in development. I'll skip over these and just highlight that there's a few future directions. We're identifying different CAR constructs and antigen targeting that may account for the differences in toxicity profile to hopefully make safer CARs. We're exploring toxicity profiles in lymphoma and CNS disease, non-B-cell malignancies. We're optimizing early intervention strategies to minimize toxicity and early identification of patients who are at highest risk of relapse and who may need these strategies, hopefully shifting these treatments to an earlier phase of therapy to have less heavily pretreated patients. So again, thanks for your attention, and I think we'll move on to the next talk, Bob, or do we want to do questions? Okay, thanks.
No, okay. Yeah, so regarding the CAR-T for solid tumors and that increased incidence of HLH, MAS-like syndromes, do you think there's an underlying like predisposition? Could they have like a variant of unknown significance with like related to familial HLH? Maybe not having familial, but like, is there something underlying that could be?
I mean, that's certainly one of the things that we've looked for. We haven't found any of the sort of canonical, perforin, granzyme, that kind of thing. One of the thoughts that some of the scientists I work with have said is that it may be a result of tonic signaling, that if you can imagine a CAR T cell sort of approaching a big mass of a solid tumor and that it's constantly interacting with its target rather than killing one liquid cell, then moving on and having some rest and finding the next one, that it's just constantly trying to chip away at this big solid tumor. That sort of tonic activation of the CAR signaling may somehow mediate this, but it's still a large unknown.
Other questions, guys? I can bring the mic to you.
Hi, great talk. Fred Goldman. I was wondering if you could tell me the status of off-the-shelf CAR T cells, because manufacturing and pheresis is an issue, and we're doing that for viral-specific T cells and other things. So where are we?
Yeah, this is a really, really active phase of development. All of these are still in early phase 1 or early phase 2 development. And the thoughts are either could you use genetic engineering strategies to knock out some of the proteins that may mediate rejection or recognition by the patient's immune system, so knocking out HLA on the T cells so they aren't recognized by the cancer patient's own immune system. And then the other strategy that's kind of exciting that I think is happening is in vivo CAR delivery. So essentially using viral or non-viral vectors and injecting them directly into the patient. So rather than taking out the T cells, injecting the virus in a bag and then waiting 3 weeks to infuse, you may be able to skip that manufacturing step by just delivering the CAR construct directly to patients. So those are all in early phase. I don't have any data about their effectiveness.